Thank you very much. And just again, want to congratulate Dr. Krishnan and the organizers. I mean, this has been an amazing conference again this year, and the faculty and those in attendance really make this a real success. These are my disclosures. So we're going to talk about, the advantage, I think, and why we can utilize TCAR for these patients. And I think we're all familiar with the arch classification, and the more complex arch can be more challenging. This is a patient we treated transfemorally, but this is like a type 5 arch. And it requires a lot of additional manipulation. It requires a reverse or double reverse curve catheters, more maneuvering within the arch, and there's frequently atherosclerotic burden there. So if you can avoid that can be beneficial. And here we're advancing our sheath over our guide catheter and our wire, and you can get the sheath into position, but again, it's a lot of maneuvers. If there's proximal disease, these can all be challenging and potentially increase your risk. You can avoid that with TCAR. Bovine anatomy can be challenging as well to get transfemoral access, although transradial access is often effective, as you can see there. So TCAR enables us to avoid that whole manipulation of the arch and access through the arch. I think, as most people know, it utilizes direct access into the common carotid artery, and then you initiate flow reversal so that you have embolic protection for any debris liberated during the angioplasty and stenting by reversing flow through the internal carotid and back through the en route sheath in the system and returning it to the venous circulation. And that's very effective. The data, I think most of us are familiar with, all point to a very safe and effective treatment modality. Here is TCAR being compared to historical data on high-risk endarterectomy patients and demonstrating superior outcomes in that high-risk population. Again, in the Roadster study, the excellent device and technical success, 99%, and excellent procedural success as well, so it can be done quite effectively in this trial format. And the stroke rates are really quite low and very, very acceptable. The stroke rate on intention to treat basis, which I think is the most important to look at, is 1.4%, and then the combined stroke and death rate at 2.8%. So again, really excellent outcomes. So I don't think that's what our discussion is really focused on. One other point, though, is to look at these high-risk patients in terms of older patients. For transfemoral stenting, we identified early on a higher risk for those who are older than 60, older than 70, or those older than 80. That was not seen in the Roadster trial. So this is a case, I think, just typical where transcarotid artery revascularization can be utilized. This is a patient of mine with a type 3 arch, and then extensive sort of tortuosity within that proximal left common carotid artery. So we were able to avoid manipulation of that entire area by doing a direct transcarotid access. And here's our preoperative imaging of the lesion. And then after angioplasty, you can see our cut down here, our en route sheath, and after the revascularization, excellent flow, and this patient did quite well. There we go. Dr. Krishnan wanted me to discuss using this for every single patient, and we don't need any other techniques for revascularizing the carotid. I don't know that that's true, but here's a patient that we treated with a really densely calcified lesion. Almost looks like an old dissection with extensive calcification and then sort of a critical stenosis. And here, we treated this patient with TCAR. So this is our initial access. You can see the Wheatlanders here and our micropuncture wire that's present. And here's our lesion. Also a very small internal carotid in this case. And this is after we put our en route sheath and get ready to initiate our flow reversal. But anyway, nasty plaque there that we're concerned with respect to embolization. And so we initiated flow reversal and went ahead and wired through that lesion. I was concerned that we may be in a dissection plane, so we advanced a microcatheter up and just confirmed interluminal positioning. You can see we treated the other side previously with a lesion. Went ahead and did our angioplasty and stenting. Here's our stent after it's been deployed. And these are just our completion angiogram, which shows really good resolution of the stenosis and preservation of intracranial perfusion. and this is just a pre and post imaging. So that was done with shockwave, again, due to the extensive calcification. I don't know if I can recommend shockwave routinely. We burst the angioplasty balloon in that case, and we could see, I guess our balloon prep wasn't quite optimal because we could see the air bubbles tracking back through the tubing. It did show us that our flow reversal was working, so it was reassuring in that regard. This is another case in which we're sort of extending the indications for TCAR. This is a woman with a carotid artery aneurysm or pseudoaneurysm. She'd had previous bilateral endarterectomies and then a redo endarterectomy on the right. And if you look at this image, you can see, I think, this pulsatile mass. You can't say it's pulsatile, but it was visibly pulsatile to exam. And here it is, just a more magnified view. This is her CAT scan. And we'll be focused on the right, obviously. So as we come up the common carotid, it looks okay. She's thin as we observed on physical exam. And then there's this very large aneurysm with extensive thrombus burden and then good flow into the distal internal carotid. Here's just a still image showing it's about 3.3 centimeters in maximum diameter. So we wanted to treat this predominantly for the embolic risk. We've been utilizing endovascular approach with stent and overlapping stent placement for treating these pseudoaneurysms. And it's been very effective, at least in terms of midterm outcomes. Here's our arch angiogram, and I'll just point out there's extensive disease within the arch, and here's that pseudoaneurysm or patch aneurysm that's present there. But again, a type 3 arch, just going to be challenging to access through all that extensive disease, and this is just an AP projection. And so we did TCAR in this patient as well. We got our sheath in. We initiated flow reversal. You can see the extensive thrombus burden outside of the flow channel. It just looks like it's ready to embolize. And here we are on a roadmap to image. The first stent has been deployed, and now our second stent's being brought in position. And that's sort of the approach we've been using a lot for these pseudoaneurysms. And that gave us a nice result. Now we still see some flow. We're still anticoagulated on dual antiplatelet therapy, so you do tend to see some flow preserved initially. But she came back and saw us at 1 month postoperatively, and this was her duplex exam. And again, good transverse imaging, excellent flow in a stent, no flow in the aneurysm sac external to the stent. And this is the longitudinal imaging. Again, here's her stent. You can make out the borders of that. Good flow and no flow in the excluded aneurysmal component. So TCAR can't be used for everybody. This is a patient of mine. He's had radiation therapy, laryngectomy for his laryngeal cancer. You can see dense scarring, making any sort of surgical dissection in this area very, very challenging with respect to cranial nerve injury and identification of other structures, and then, of course, the infectious risk of having a stoma being present there. But here's his lesion, and we've seen these complex lesions in these irradiation patients, but sort of a 100-degree turn and then a 130-degree turn and multiple ulcerations and high-grade stenosis. So this was challenging to do transfemoral, but I thought it was really his only alternative, and we wound up having to use 2 buddy wires, and then finally could get our distal embolic protection into place, and that was ultimately successful. And in this case, most of the time we use a closed cell stent, but for this we use an open cell stent just to conform to those turns. And just one other patient that we used the transfemoral approach on. Again, same thing, neck irradiation. He'd had parotid cancer, I think it was, and with 30 rounds of chemoradiation. So this was just a solid piece of what was like a board, and really not a good candidate for attempting any sort of cervical approach. And he had a common carotid lesion. You see his left common carotid here as we're coming up. Sorry that this is kind of running a little slowly, but diffuse disease, I think fairly typical for these radiation-associated stenoses. And he had he was referred to me for his transient ischemic attack that he had experienced. So we wanted to go ahead and treat this lesion, and really the only alternative, I think, in a patient like this is to do it via transfemoral or potentially transradial, but I think transfemoral gives you a better shot at the ostium of that left common carotid artery. So this is just a still image of the arch angiogram. He was moving, but here's our arch. Here's that diseased left common carotid with multiple areas of critical stenosis, symptomatic patient. And here's our initial diagnostic image. It almost looked like an old dissection, actually, and it turned out to be quite an involved process to get that revascularized. But we deployed two closed cell stents through that distribution and got what we felt was good resolution of that stenosis. So I would just conclude by saying both TCAR and transfemoral carotid stenting offer complementary approaches to carotid intervention. Unfavorable access vessel anatomy, particularly challenging aortic arch, I think does favor TCAR. Transfemoral stenting may carry a lower physiologic stress, however, for these patients. And it's, I think, preferred in patients that have a limited length of common carotid. You need to have enough length in the common carotid to get your en route sheath into position and enable you to do the angioplasty and stenting. So there are anatomic constraints to both of these procedural approaches. It may provide an advantage to transfemoral stenting may provide an advantage to patients with severe neck irradiation, and both share the limitation of being difficult to employ when you've got extensive calcification. Those patients remain very challenging to treat with any stenting modality. Thank you very much.